Okay. Some slides, some study has just been presented by the previous speakers, and so I will try to run a little bit. Anyway, there is still no agreement, as you have just heard, about which is the best technique to use after a pancreaticoduodenectomy. I think there are different points to be analyzed. The type of pancreaticojejunostomy, pancreatogastro versus pancreaticojejunostomy, the different types of pancreaticojejunostomy, which come up in the different papers, the use of stent versus no stent, the use of glue versus no glue, and which glue, because if you go in the literature, there are different papers with different points. I mean, the first problem is pancreatogastro versus pancreaticojejunostomy. The randomized clinical trial are really these four, at my knowledge. If we look in this one of the first from the Cameroon group, and it seems at that time there was no difference between pancreatogastro and pancreaticojejunostomy, and there was no significant difference between these two studies. There was another study, multi-center French study, published in 2005. This is a study where I think I would say a lot of confounding factors, because surgeons are allowed to do, I can say, what they want. I mean, they can use octreotide, they can use glue, they can make everything. And so this makes probably a little bit more difficult to analyze the results. Anyway, in this paper, it seems that comes up that some particular patients, small ducts and soft glands, have at major risk to have pancreatic fistula. And then comes the paper from Verona, Claudio Bassi and co-workers, which had been published some years ago. And again, it seems by this paper that there is a small but definite advantage of pancreaticogastrostomy versus pancreaticojejunostomy, at least for some particular parameters. And then, again, the fourth study is the study for Fernandez-Cruz with this particular type of reconstruction he showed us very beautiful this morning. And again, in this study, seems that this reconstruction allows a better results in terms of control of pancreatic fistula and complication as regard to the pancreaticojejunostomy. If I can make a comment, it seems that there are 4 studies with different type of pancreaticogastrostomy. There are a pancreaticogastrostomy retrogastric, there is a transgastric, there is a gastric partition. I don't know if this can influence results, but we have to bear in mind that when you analyze the results, we are not talking probably the same language. And then another topic is the different type of pancreaticojejunostomy. Again, there are 3 major RCT. The first is from, again, the group from Verona. It doesn't seem to have any difference if we are performing a duct mucosa or an end-to-side pancreaticojejunostomy. And then comes the work from Pang, and it's a work that makes some rumors that, in fact, with the binding anastomosis, there are no fistula, and it seems that a little bit astonishing if we are looking at the result even from the best group that I think most of them are here today. Anyway, it seems that with this particular type of binding anastomosis, the control of the pancreatic fistula seems to be definitely better as to the conventional group of pancreaticojejunostomy. And then there is another trial from Johns Hopkins again, with duct to mucosa versus invagination, and here seems that the invaginations allows better results of pancreatic fistula. Again, different to get a conclusion, because there are, as we've seen, different trials. Stent versus no stent. Two RCT, because the study of Roeder is a prospective, not randomized, coming from German. Again, different study because some there is internal stent and the other is external stent, and so they are not exactly the same. This is the paper from Roder, the group of Sievert in '99. It seems to have a definite, it seems to have an advantage with stent patient, but it is not an RCT. This is the study from the group from, again, from Johns Hopkins, which comes up with no statistically significant difference between the use of a stent versus no stent. And this is again the study of Poon from Hong Kong. And here seems that above all in patients with small duct, there is a definite advantages for external stenting in this study. And the authors recommend the use of this stent in their paper. And at the end, we come to the use of glue. Again, which glue? There are different papers in the literature. The paper from Professor Di Carlo and the group of Notre Dame the one group used AT-block and the other group used neoprene versus pancreaticojejunostomy. And then there is the multi-center study from the Association Française de Chirurgie. We use fibrin glue versus pancreaticojejunostomy inside the duct. And the study from the Johns Hopkins, we use the glue over the anastomosis versus no glue over the anastomosis. So again, different confounding factors and not exactly the same kind of patient that we can use for our conclusion. This is the study from Italy and Holland. And you see that seems that there are no advantages and no reduction of complication by using by gluing the duct versus a pancreaticojejunostomy. And this is the other French study, multi-center study, with again comes to the conclusion that ductal occlusion by intracanal injection of fibrin glue decrease neither the rate nor the severity of intra-abdominal complication after pancreatic resection. And this is the study from John Cameron and his group in Johns Hopkins. Again, again, seems that there is no difference between using a glue, adding a glue to a pancreaticojejunostomy. And so, what to do? It's hard to draw a firm conclusion. It seems that there isn't a technique that is better than ever. All these randomized clinical trials, or most of these randomized clinical trials, have some flaws and confounding factors that make much more difficult to get a conclusion. And so we live with two options: centralize the patients, above all thinking that single center results seems definitely better. You have heard the single center from the group that had the major experience in pancreatogastro, from Strasbourg, from Professor Traversos, from Marcus Buchler, and the other. Or we have to adapt the technique to the single patient, knowing, as Bill Traverso showed us, recognize the high-risk patients. I haven't a definite conclusion. I just want to stress again this paper from Italy, which again shows that probably we need to centralize the patient. So if you want to reduce the postoperative mortality of this patient and so to give a better future to our patients. And or adapting the technique to the single pancreas, coming, if we look at this paper from the group from Peng, again, high-risk patients are those with a soft pancreas and with a small duct. And in these patients, probably, if we can adapt a particular technique if we want. As it is indicated in this paper, it was the binding on other technique. And so at the end, which is the preferred way to follow, I don't think the balance is not fixed again. Adapt the technique, or always standardize the technique, as Marcus says this morning at the end of the operation. I have no definite answer at this moment, and probably I will leave this question for the discussion at the end. Thank you.